All
Okay,
right.
good afternoon. Good afternoon. Thank you for joining us. If you are just logging into our Zoom session, you are here for the Firefighter Cancer Initiative monthly seminar series. So we'll let you come into the room, adjust your volumes, and we'll get started in just a moment to introducing our speaker. So just give a minute or so for folks to jump into the Zoom, and then we'll get this party started. Okay. Okay, afternoon, everyone. As you're populating into the Zoom session, we're going to give a minute or so for folks to settle in and adjust their audio and video feeds, and then we'll get started by introducing our guest speaker.
All right. So I think we can go ahead and get started. I will start our introduction. We're really excited today. Our medical director for our firefighter cancer prevention and wellness clinic, Dr. Chris Paultre, will be presenting today. Uh, Dr. Paultre is a board-certified family medicine physician with fellowship training in sports medicine from the University of Miami Sports Medicine Institute. He serves as an assistant professor of orthopedics and family medicine, specializing in sports medicine, primary care for athletes at all levels. Dr. Paultre has presented at national scientific meetings and published multiple research studies. A graduate of the University of Florida College of Medicine, he completed his residency and fellowship at the University of Miami Jackson Memorial Hospital, where he also served as chief resident. Dr. Paultre has received notable awards, including the 2020 AMSSM Harry Galanti Young Investigator Award and the UF College of Medicine 2016 Primary Care Sports Medicine Award. So, as I mentioned, he does serve as our lead for our clinic and our medical lead. And so we're so excited to have him here today to talk a little bit about an issue that we know is very high on the priority list for our firefighters, musculoskeletal pain among firefighters. So with that, I will hand it over to Dr. Paultre.
Cool. Once again, thank you so much for having me today. I believe I gave a lecture very similar to this, almost exactly like this, roughly 2 years ago. Just going over, musculoskeletal pain amongst firefighters, what's most prevalent, and also what current research is being done and what preventative methods are being employed in order to reduce these risks for our firefighters. And we'll go through some of those changes. You'll notice that a lot of the slides are very similar because the most up to date that we had roughly 2 years ago data for occupational health is still around the same. It's not, there haven't been significant differences. So starting off, let's see here. I also want to mention that I'm technologically unsavvy, so I always have issues here. All right, so the objectives mainly to describe what are the MSK complaints of the general population and compare that to what's the pathology of around firefighters. There are a lot of similarities, but in firefighters in general, I like to look at it as a tactical sports medicine in my field, and you guys have a lot more burden on your bodies. We'll look over the current screening tools for prevention of MSK injuries and discuss the morbidity in the future, as well as to summarize some of the research projects that are going on here at the University of Miami. So, in the general population, MSK injuries are, they're significant. They're still 1.71 billion people have musculoskeletal conditions worldwide. That is probably a conservative estimate. It is the leading contributor to disability worldwide, with low back pain being the single most leading cause of disability. Why is that? Well, if you think about it, you have knee arthritis. There are ways to have a knee replacement. You can have the clinic I'm in right now is actually the ortho joints clinic. So hip, knees, and shoulders, we can eventually get you to a solid baseline. The lower back or back pain, that's a much more difficult area to deal with, mainly because of the spinal cord and neural cord sitting there. Um, top identifiers of top risk factors for MSK injuries. Number one, age, whether or not you've had traumatic injuries, occupation, and genetic predisposition, of course. There we go. So what is considered a musculoskeletal disorder? Now, this is where my field kind of merges with rheumatology, merges with neurology, with neurosurgery, because a musculoskeletal disorder is on the general guidelines throughout the CDC, throughout the WHO. It's pretty varied. It's pretty wide. So it's any injury to the disorders of the muscles, nerves, tendons, joints, cartilage, and spinal discs. That's a very wide range. And so for what's preventable, you can see that it's difficult to actually, when we look at how prevention, we usually like to limit our variables automatically. The nomenclature of musculoskeletal disorders makes that very difficult. Now, work-related musculoskeletal. Oh, Jesse Schilling just raised hand. Go for it. Make this interactive. If you have anything to ask, go for it.
So with this seminar, if you have a question, please put it in the chat or the area that says Q&A, because we're not able to hear
Oh,
the
okay.
the voice
No
of
worries, no
of the
worries. So we'll
members.
definitely, Jesse, we'll get you. We'll answer every question we can at the end of this. So I'm going to make this pretty short and sweet, and we'll go from there. So work-related musculoskeletal disorders, if they're looking at the environment and performance of work that contribute to your condition, or if you have an underlying condition, what can make it last longer or persist, or any conditions within your general work occupational area that exacerbate these issues. It's kind of pretty common sense there. Why is it such a focus? Well, just in the private sector alone, year of 2020, I mean, the new injuries account for a loss of revenue. So I care about firefighters. Though a lot of people in politics, a lot of people look at what is the GDP. Um, Private sector, that's what you look at. How every company looks at what is the loss due to illness, loss due to injury, and how do we prevent that? Especially if certain jobs are construction for lack of better examples, physically demanding positions, loss of MSK injuries cost a lot. So on 2020 alone, the private sector for that year, about over 200,000 new injuries requiring days off of work. The median days of work was 14 days versus 12 days for all other injuries, flu, and this is the year of COVID. So looking at that information is impressive. Morbidity, as well as the increased morbidity at home. When one person comes out, especially a primary breadwinner, then the rest of the household does even more poorly, and it ends up being a snowball effect. So it's a huge focus. And look at the most common in the general population and private sector, most common sites of injury, a lot of upper extremity, a lot of lower extremity, but significantly back. Back seems to be a big hitter for a lot of different reasons. Now, the nature of injury. Is this, will this become a chronic issue? Is this just a strain or sprain? The way it's done right now and how they look at this, I really do not. You'll notice that in the ICD-10, which is the coding we utilize for diagnostics, there are a lot of injuries to be, that I just don't agree with how they're placed on there. Lower back pain means nothing to me. There's a lot of muscles on the lower back. I like to be a little bit more detailed. Is this a disc issue? Is this a actual paramuscular issue? So those things are very difficult to measure on these work related surveys, and so we don't get the exact nature of what is a sprain, strain, or a tear. But primarily lower back seems to be a big issue. A big thing is overexertion, bodily reaction. Overexertion involving outside sources, and issues with lifting or lowering. So we see this a lot in the disability or the DWC, the disability work paperwork, where we have to kind of place down a diagnosis and we go through, what are the limitations. So when we see somebody for a work-related injury and they're going through um, their healthcare system and they're looking for they're getting disability, usually it's short term, and they'll ask us exactly what are they able to do, what they're not able to do. They'll, a lot of job sites are okay taking somebody to their 50 percentile of their production as long as they can be in a seated job. So in the general population, it's a huge issue. How do firefighters compare? It's hard to get these exact numbers. It's also hard because another variable that we throw in here are not all firefighters are the same. The Northeast to South, the individuals who handle the forest work, military firefighters, there are you guys are such a broad, uh, you guys are such a broad spectrum of individuals of what you guys actually do, that that can place a lot of difficulties in kind of narrowing things down and how do we in prevention aspect of this. I was talking to somebody roughly a year ago discussing it from Boston, saying that their biggest issue is getting people down, especially when elevators are down. A lot of their guys get hurt when transporting downstairs or utilize, stretchers have gotten a lot better, but transporting it seems to be the area where they all end up getting back pain, knee issues, and that's the big risk versus somewhere else it's been slip and fall. So it's very difficult. But it's hard to get the exact numbers. In 2021, NFPA estimated about over 60,000 injuries. In 2012, Rand Health Quarterly looked at in California, the Bureau of Labor Statistics demonstrated that firefighters are over three times more likely to suffer work-related injuries to the MSK system. They take longer to return because the injuries you guys get are significant. They're worse. You have so many environmental factors that just make this that make it's the reason why your job is dangerous. You have so many things you have to look out for. Um, on most return to work compared to private sector, it's 1.4 times more likely. But a key thing to look at is on musculoskeletal disorders, it actually takes twice as long, two times more longer to return to work. You guys have increased frequency and increased severity. And these things do get worse with age. So age is a big risk factor than younger. Younger guys can bounce back. The older firefighters are 10 times more likely to suffer injuries, and also it takes 4 times longer for them to return back to the baseline. You guys have a pretty rigorous job. Most common injuries, and when I say most common injuries, this is not really looking at the sequela of your retired firefighters and what they're suffering with for the rest of their lives. So sprain, strains, and muscular pain are the most prevalent of all type of injuries. You pull your shoulder, you pull your back, you pull your neck. Um, Most of them are caused by a way of overexertion from falls, jumps, or slips. I'd like to, in my personal view, I do think that lifts are also something that should need to be looked at, even with the updates and even with the updates with you know um, gurneys between 2012 and 2014. The They looked at the age and where in your career are most likely to have these injuries. It usually peaks between 40 to 44. Why is that? You know, for me being 36 right now, I just had my own injury. So your body doesn't heal the way it does in your 20s. Mid-career, this is where there is some concern that there might be a loss of muscle mass during this time, or for some reason, a loss of endurance, a loss of strength during this time. You're using more of your experience. You are more experienced, but you're also taking on the brunt of the workforce. Um, and those are all things that come into play. And so you're trying to manage more. You're having more of a leadership role within your department. You're trying to manage more, teach younger guys, and then you're putting yourself at higher risk of harm. So those are all possible reasons why this occurs. But the most prevalent locations, shoulder, knees, and spine. Again, if you look at this, these are just numbers here. It shows the total annual injuries reported for these years, and you can see they're continuing to go up. They stay pretty stable overall, but they continue to rise. And they look over once again, is it motor vehicle? Is it overexertion, strain, fall, slips or jumps, struck by object? All these are the reported cases that look at the MSK injuries. So significantly prevalent if you look at it compared to the rest of the other causes. And this is just more information showing that within the same survey, 2015 to 2017, looking at the overexertion and strains, the versus exposure to hazard burns, things like that. That's still the top cause of injuries for MSK. Volunteer versus career firefighters, there's a significant increase in risk when you go from volunteer to career. The time frame that you put in there, it just shows that the more time on the job, the more likely you are to get injured. That seems like common sense, but it does take a lot of data to be able to confirm that. Once again, looking at lower extremity, look at all different parts here. So this is just once again comparing the volunteer to career firefighters body part, where you're more likely to get injured. It's actually pretty equivalent. There's no significant statistical difference between where you're going to get injured. It's just how likely are you to get injured. The more time you're there, you're going to have more of the same injuries. As you can see, they did a pretty bang up job in terms of going in and actually surveying all the where these injuries occurred for the NFIRS studies. Severity here, injury severity. This is another part that they really like to look at is loss of time. So all this is just surveillance work. It really just tells us that we know this is an issue. We know that a lot of individuals, they will go back to work. The one that gets mistreated by a physician, no loss of time. That's the second portion here. What really gets me here is that this allows us to realize that a lot of, one concern I always have is going on to a rigorous job and a dangerous job while you're hurt. No loss of time. Firefighters have a tendency you guys have a tendency to be pretty tough. Coming back to a workplace where you're putting yourself at risk again, while not at your 100%, that is something to be concerned about. There isn't currently any true guidelines except for the treating physician's opinion as to whether or not you're ready to go back. And a lot of times as physicians, we look to firefighters and ask them straight out, how do you feel? Do you feel like you can go back to work? I'd say about 7 out of 10 firefighters I will ask that to will say, please do not put me on light duty. I will go back to work right now. Um, and even though it shouldn't bias your judgment, it does. And so you're more likely to allow somebody to go back to work. It's just how it happens. Firefighters can at times minimize the injuries to their body. So this is something I just find very interesting. So age and gender, we discussed that 40 to 45, you see in men. And this is, so we also have to look at gender as well, but age-wise, 40 to 45 seems to be that spot where it's a perfect spot for individuals to get injured. That just happens. It's your body's is starting to slow down a little bit. You're still going out there for a lot of active calls. Now, in females, it's a little different. I've met many female firefighters, and they are pretty gung ho. So the younger females have a tendency to be injured at a younger, or sorry, to be injured at an increased rate. So females between 20s to 30s, especially at that 20 to 25 year mark, I see the same type of mentality with a lot of like my sister and nurses, that they like to take a lot on themselves and they want to, and there are biological differences between guys and girls in terms of injuries and what type of injuries they get. And they have a tendency to put themselves out there more, and they can actually have a higher amount of injuries early on. As they become more seasoned as a firefighter, that starts to drop down. Their numbers start to equalize with the men. Sleep and injury. As I mentioned before, that there are a lot of different factors that affect firefighters. Sleep, injured or ill, physical conditions, all these are things that we have to think about. And with the shift work, nighttime firefighters, there has been shown association between night shift or between sleep deprivation and injuries. You're just not as quick on the job, you're mentally fatigued. All those things are important to look at. So we kind of mentioned this. Every single slide I mentioned before is just documented data showing that there's a lot of factors affecting MSK injuries. We already talked about age. We talked about gender. There are previous injuries, illness, environmental factors, your gear, your fitness level already, obesity, any supplements you're on, individuals who are taking like anaerobic steroids, or individuals who are on testosterone. That does also carry a risk of increased tendinous injuries, which take longer to recover from, and a vast majority of them are surgical. Cardiovascular health, the newer studies have shown a significant association between cardiovascular health and the likelihood of having an MSK injury. This is one that's been repeated numerous times, and it's probably the only area where studies have been consistently performed to show the more fit you are, the more cardiovascularly fit you are, the less likely you are to have an MSK injury. Um, the fitness, I always like to look at where can we make changes. We can't change age, we can't change we wouldn't want to. Previous injuries, you can't always control those variables. Being ill at the time, you can control that. If you're sick, stay out. But even though if that's fathomable, or if that's easily done, that's a different statement. We can try to control environment, but the whole job of firefighters dealing with the environment. So that is a very difficult area to control. We can control gear to up to a certain point. A lot of the gear is protected, but it may not be ergonomically set. We can control fitness level to the best of our abilities. We can help to control obesity. We can control supplements, and we can work on cardiovascular health. So there are a lot of factors here affecting MSK injuries that we can actually control those variables a little bit to some degree. How do we do that? One of the studies is, does obesity predispose to MSK injuries? The answer is yes, a resounding yes. Numerous studies, every single one of them showed that there was an increase with MSK injuries with decreased physical activity levels and increased BMI, and not even BMI per se, but really, BMI is, we used to look at BMI as a go-to standard, but honestly, I think your belt size matters more. BMI encompasses quite a few things. Body fat analysis, bod pods, I think those are a much better way of looking at this. In 2012 at USF, they did look at obesity as well as core back strength, showing that decreased muscular endurance with those with higher BMIs. But that, the limitation that they did mention in that study is that some individuals, it didn't really match up, as their increased BMI was due to the increased muscle mass. So those things do have to be accounted for. So I would say, for me, decreased core back strength and increased body fat analysis. What are we using now? They're working on the NFPA 1584, but the 1582 is the classic one over the past 5 years that's been utilized to make their recommendations on things like body composition, grip strength, leg strength, arm strength, muscular endurance, flexibility, core strength. It's recommended, but a lot of the testing is only really required when firefighters first join for a lot of the PATs. Also, when they're in the fire academy, when they have to graduate from fire academy, a lot of these exams are given only then. Um, each department does things very differently. Each state does things very differently. So there's so much variability amongst the departments across the country that it's hard to really get a good idea of what the baseline fitness level should be for firefighters. Even trying to do surveillance data, and this is one of the things that I've been trying to look at and haven't ran into issues for. That that poses a big just poses a lot of difficulty in just gathering baseline data. Can this prevent injuries? The 1582. Now, this study was done in 2010. This is probably the best study I've seen. I don't know how they got away with this, because and this is what's scary. This is probably the biggest fear across firefighters is if I don't pass a PAT, if I have a required PAT based on certain guidelines, if I don't pass, what happens to my job? And I agree. But this was done over there. They were put on light duty, but in 2010, in Bethesda, they're over 2 year course. They're looking at individuals who are able to both the cardiovascular aspect as well as weight loss, or the cardiovascular component of the NFPA, as well as the strength training. They noticed in year one there's a 40% injury reduction. How they calculated that was with their disability, with their workers' comp. They looked at a significant cost reduction for the injuries. Year two is actually a 60% injury reduction. And on top of that, it also showed, because in order to get back into active duty, you had to meet those requirements and stay within those requirements. it actually showed a significant decrease in weight loss or improvement in weight loss, as well as cardiovascular health improvements. So there is something to this, but I don't think that we have it nailed down tight yet. The most recent, I was going to add another study here that was done very recently, and it was a meta-analysis or attempt at a meta-analysis and systematic review, which is technically the highest level of evidence you can have, looking across the board at both firefighters, cops, and military, and they're looking at do these tests, do they actually reduce the risk of injury? The issue for that is that there's so few studies out there that they had to add another group, which were athletes. And in the athletic population, number one, sports science is a very interesting research group of individuals who is different than sports medicine, where they will take a lot of pseudoscience and add them in here, take random measures that haven't been validated and act on them, which I think is a bit crazy. But because of all that, they were not able to come up with anything. They said that this is just impossible to do. It actually dropped their systematic review down to almost a scoping review, which doesn't really entail any data. It just says, it pretty much said this needs to be done across the board between firefighters, cops, our military personnel, and our athletes. You know, the reason why a lot of the guys hear about this, the peptide therapy and peptide injections are because of sports science, even though it's never been validated. So the U.S. firefighter workforce is significant between career firefighters, and it's like it's almost a 60-40 split between career firefighters and volunteer firefighters. This is just based off of our workforce right now. Now, in Florida, the workforce is about 70 career and volunteer firefighters. It's a similar type of split there, 60-40 split. Now, retired firefighters, a lot of the data now looks at the role of active firefighters, but these musculoskeletal disorders, they change. It's no longer that sprain or strain look. It doesn't, if you looked at the previous, if you look at the previous statistics there, and some previous data, it looks almost solely at active firefighters. Now, MSDs don't stop there. These musculoskeletal issues, you know, tendonitis becomes tendinosis, which becomes tendon tears, which becomes arthropathy and arthritis. This is a spectrum of issues. So those common repeat strains and tears and repeat injuries, once you retire, that becomes arthritis. It becomes an increase in instability in the joints. That becomes an increase in pain, a decrease in your sleep hygiene. So the retired firefighter is a group of individuals who I truly don't think I think we have neglected slightly. So we really need to start assessing more and start looking at retired firefighters and what they suffer from. It's one of the reasons why here we started the aerial study. This is we're still enrolling individuals, but this is still at the, you know, this is one of the studies that we are doing. It's the aerial cohort research study by Dr. Caban, who's on here right now. So what is the objective? Is to know about what MSDs and musculoskeletal pain reported by incumbent firefighters. We already acknowledge that there's little known. We want to characterize the musculoskeletal disorders and examine predictors of multi-site pain. Your body's a chain, so you start somewhere. It's almost like a car. One thing goes bad, the next thing's going to go bad pretty soon. So it's, the FCI was established in 2015 at the Sylvester Comprehensive Cancer Center, working across disciplines. They're looking to advance the epidemiology amongst retired firefighters at a longitudinal level. So not just stopping right there. We want to get, you know, long-term data. There was baseline health survey data, as well as one of them was the anatomic location and frequency of pain. Chronic MSK pain it was done very simply as no pain, single site pain or multi-site pain. This is Dr. Caban's favorite part, is more of the statistical aspects of this in terms of multinomial logistic regression models. I'm much more of a clinical researcher. So when we get to the data aspect, I kind of hide away, and the number aspect, I have to go and always remind myself what everything means when I'm reviewing papers. But they were used to identify the predictors of MSK pain. So and this is older data. We have included more. This is from around about 2 years ago or a year and a half ago. So over 490 retired firefighters within Florida. 46% had no chronic joint pain, while around the other 50% had multi and single site pain. Similar to where we were with the main population and non-retired firefighters, lower back seemed to be a constant site, and for especially amongst individuals with multi-site pain. Um, Individuals with multi-site pain, and this is one thing that I always like to hark on. Pain affects every part of your life. Arthritis, that a lot of times is the cause of the pain, but that pain keeps you up at night. That loss of sleep also will increase rates of depression. So multi-site pain showed a significant increase in depression, sleep disorders, and arthritis rather than single site pain or no pain. So pain, especially the more pain you have, the more MSK injuries you have, the worse the rest of your body is able to compensate for it. In those result reporting multi-site pain, this is kind of just going on that there's an significant increase in obesity, depression, sleep disorders, and arthritis diagnosis. And that's looking at the adjusted odds ratio. Now, in trying to over the past year, I had the opportunity to work with a med student. He's an MPH1 Dr. Command student. Stephanie Cole. He's a pretty smart kid. I say kid. He's like he's not too. He's a bit younger than me. But one of the aspects I've had issues with is just figuring out what everybody is doing and what the reservation is about doing PATs, and because everybody does things differently. The FAST-C survey, which was recently administered, we're looking to improve it. It was recently administered in Orlando over the past 2 months, and it is essentially to look at what is being done in terms of, number one, your physical fitness and what your primary exam that's required by occupational health. Are PATs being performed, and characterizing those PATs, as well as also asking a few questions about the reservations amongst firefighters with regard to PATs, whether or not they think it's effective, whether or not they think it's a big part of this. And I think this is a good starting spot in terms of possibly making changes and just gathering data and look at the variability amongst firefighters across, or fire departments across the country. Being able to characterize that first step can allow us to say, hey, these are the tests that are most commonly being done. Let's, in a controlled manner, see whether or not specific tests can prevent injury, and look to see whether or not it's actually worth to put money for it. Because let's say that some of these PAT tests, or that some testing doesn't do anything. It could be the exact opposite of what we think. If that's the case, then rather than wasting money in terms of trying to screen for this, because we haven't figured this out even in sports, why not put the money towards rehabilitation? So it will allow us, just having more data can allow us to allocate funds in the future for different types of rehab and screening processes. The conclusion for the ARROW study is that multi-site pain was associated with obesity, depression, sleep disorders, and arthritis. So workplace interventions have been tailored to incumbent firefighters. They should focus significantly on screening, ergonomics, and injury prevention to limit musculoskeletal issues during prevalence during retirement. So dealing with it during active duty is going to help out as well during retirement. These were sources, and I'm happy to take any questions and talk further. I usually like doing things in more of a panel discussion type way, so I could get everybody's questions and also review the data.
Awesome. Thank you so much, Dr. Paul. And so you already have a few questions that have come up. So
I would
probably see them, but I'll read them out loud. So controlling for the type and circumstances of an event, does BMI versus BSA versus percent fat analysis play a factor in occurrence and recovery versus age of firefighter?
Yes.
So there's a few questions here, so I'll start with that one, and then I'll continue.
Absolutely. At every level, we actually adjust. I always love looking at this in terms of football players, because football players come in every size and it's all positional, but their injuries are completely different. they may have a high, they have a high BMI, they have high muscle count, but their fat count and the alignment are always higher. So you'll notice certain specific injuries that consistently happen. Um, I personally think body fat analysis plays a bigger role. Your increase in body fat and body fat percentage is much more important than your BMI. Um, I would much rather have I say this in a polite way. I'd much rather have somebody who's weighing 250 pounds that looks like Mike Tyson versus somebody weighing 250 pounds who looks like a hobbit. The muscle mass takes on a lot of that, and that does account for prevention. So it's an easy yes. It's really common sense for that. Now,
Great.
weight on the joints, regardless, can be rough. But if you have the muscles there to actually scaffold it, it makes it a lot better.
Great. And then another question with respect to the objective criterion, is there any value to applying the military standard to return to duty? Um, the firefighter standards under NFPA 1583, fitness testing, does have a place. In the military, there are remedial exercise programs. With respect to cardiovascular health, work, shift, sleep disorders is quite a risk.
I don't have access to the military. I haven't seen I haven't reviewed fully the military standards in terms of return to work, return to duty. But if they're more regimented, so the hard part about saying that is that even on the NFPA guidelines, the research behind the actual studies for prevention of injury, they aren't as they're good, but they're not as robust as I would like them. Because if I were to employ that in a professional team, I don't think that it's going to I don't think that's going to prevent all the injuries. You guys are putting yourself at risk regardless. Um, I and as I've been looking through screening, as I've been looking through a lot of the papers, it's been very mixed. So I think we need more data. I think we need to do this correctly. I think we need to standardize something, even if it's not the right thing. We have to take what we have now, standardize it across the board, and then look at the data. Military does a better job of that, and so I'd be happy to go ahead and look further into that and see, has it actually helped? I know the military docs for the sports medicine, they usually are the ones in charge of that, and they do a really good job on specific issues. For example, overexertion injuries. Uh, uh, things like stress fractures that are very common amongst the military recruits, they have that nailed down. Like everybody else copies them because they do such a good job of it. And that's because they're able to, essentially the recruits are their lives are within the military's hands. They get to dictate when they wake, sleep, and do everything. I don't think that would work as well in a, civilian population of firefighters because, freedom's freedom, you want to be able to have fun. But there is something to that. So that's something I'd definitely look into further. But I do think we need to standardize across the board, just to get the data so we can make the next best choice. And it may not be something that helps the individuals who are at 50, 60, who are towards their twilight of being in the fire department and going towards retirement, but it will significantly help the future. And that's what the big goals are.
Great. So the next thing is, what do you attribute the longer time required for firefighters to return to work after an injury compared to injured workers or patients in the private sector?
Personally, I think there's a couple things. When I mentioned before, the amount of firefighters who will go back into a rigorous field with injuries. You guys have this level of brotherhood, sisterhood. This you don't want to leave your other guys hanging, and so you're quicker to go back to heavy duty. You will jump in as needed and you'll minimize your pain. Whereas a lot of other individuals will say, hey, you know what? I rather take my day off and actually heal. Um, I personally think every single fire department should have a PT and an athletic trainer on there to do rehab after every injury and make it required that you guys go in and do it. So I think you guys go back too early. I think you guys have a tendency to minimize your injuries and you don't and sometimes you may not give it the exact time it needs to fully heal because 80% of firefighters hate light duty. And I think that that's one of them. And also your injuries are usually worse. Let's be honest here. even amongst other heavy duty lifters, like construction workers, it's a tough job. But I think that firefighters, when you do have an injury, it's not just a more of a chronic exacerbation on a chronic injury. It's a new significant strain. I take you guys with a grain of salt. I say that's a real injury.
Well said. Okay, the next one we have on here, has there been any studies looking at waist circumference versus height ratio versus percent body fat to see which can predict MSD better?
In sports science, they're having a couple. So it's interesting. So big boys lift big things. So if you ever look at any of the strongmen, their waist circumference doesn't look great, but they could lift big things. But if you look at the rest of their body, it is just in tatters and pieces. But in terms of actual performance metrics, body fat percentage and also waist circumference has been shown to be just better in terms of overall cardiovascular health, um, overall performance, and it might be different types of performance, and that's the other thing. Me, I like to work out. I like to do heavy lift. I like lifting. I like more of going to the gym and lifting weights. I'm never going to be able to compete against the long distance runner in that field, but in other metrics, I might be able to. So it really depends on what metrics you want to look at. But there have been studies done, a lot of sports science studies, that have shown that body fat percentage just shows a significant improvement in mainly cardiovascular health, risk of heart disease, and risk of things that can actually kill you, and also improvement in athletic performance. Now, with weightlifting, sometimes no, because a big boy is a big boy that lifts big things. That's the simplest way I can put it.
That's great. Okay, so I don't see any other questions from the group. Does anyone have anything else before we sign off? If anyone wants to put anything in the chat.
And please, if you have any questions about the UM football team right now and all the craziness, I'm happy to answer that too. The Marlins, I don't want to answer that because it's terrifying. I'm happy to answer everything, just for fun.
Amazing. Well, thank you so much, Dr. Paul. Such a great resource. Thank you for being here today and presenting, and thank you for being part of our team. Um, so, as many of you know, hopefully all of you, next month is our annual International Fire Service Cancer Symposium. So, we will not be having a seminar series next month, but we will be in person at the Shalala Center on February 20th and 21st. It is free registration for in-person and virtual. So if you are not able to travel down to South Florida, please feel free to still register. We have some great speakers lined up and a great agenda put out, really tackling some high priority topics that we've received from firefighters, ranging from mental health to cancer screening. Um, and it's also our 10-year anniversary. So we have a few things up our sleeve to celebrate. And we're really excited to see everyone there. And so we will share the event. So it is in the chat that everyone can see. Um, and you're able to go ahead and get there and register. Well, thank you everyone for being here, and we will see you next month. Take care. Bye-bye.